For patients who have high risk early stage hormone receptor positive breast cancer, we have had approval for abemaciclib in this setting based on the monarchE data, which showed us that if you use 2 years of adjuvant abemaciclib in patients who have very high risk disease, so patients who have 4 or more positive nodes or have 1 to 3 positive nodes and an additional high risk feature, you're seeing a 30% reduction in IDFS events, which translated at 5 years to over a 7% absolute difference. And that benefit, very interestingly, is continuing to be seen because we see the curves are continuing to separate even after people have discontinued their 2 years of abemaciclib. So I think that data is very robust and suggests that abemaciclib should be standard of care for all high-risk ER-positive patients. But now we also have data from NATALEE, which looked at 3 years of adjuvant ribociclib and did have a broader population of patients. So it wasn't just people who had nodal involvement. In this trial, you could be eligible if you just had lymph node involvement and you didn't need to have an additional high-risk feature, or you could be eligible if you had node-negative disease and you had a tumor that was over 5 centimeters, or if you had a tumor that was between 2 to 5 centimeters, you needed to have an additional high-risk feature. So you needed to be high grade or intermediate grade with a high genomic assay or a high Ki-67. And what we saw now at ESMO, actually with 4 years of follow-up, is that 3 years of adjuvant ribociclib did improve invasive disease-free survival with about a 30% reduction in risk of events with a 5% absolute difference between the two arms. And so I think it really establishes ribociclib as an alternative choice to abemaciclib, particularly in those patients who have broader eligibility, who may fall outside the monarchE eligibility. It gives them also an option for an adjuvant CDK4/6 inhibitor. I think the area where I'm still struggling is, do we give ribociclib even to patients with node-negative disease who have high-risk node-negative disease as defined in NATALEE? And, I think while the data look very good, even in the node-negative population, the challenge is these patients can have late events, and the number of events so far in this group is quite small. And so truthfully, I'd like to see a little bit longer follow-up on that node-negative population to really understand what the absolute benefit is there. But overall, again, I think we have choice of 2 CDK4/6 inhibitors in the early disease setting, and we really should think about these agents, particularly for patients who have high risk of recurrence.